Hiroo Takayama up to the stage. He's the cardiac chief at Columbia. He's going to talk about residual AI after root repair. That never happens, right, Hiroo?
Thanks for the invitation, Marl and Dr. David. It's an honor to be here. And quick story about Dr. David. No, I never learned directly from him, but I learned from Michael Borger, so I'm probably the grandson level for him. When I visited to Dr. David's operating room, you are very intense, and you are telling the nurses that this is not a teaching case to the trainee nurse who is clearly incapable. And I was very frightened, but you are very kind to me. And then interestingly, a few years later, I visited Dr. Coselli's OR. He was telling exactly the same thing to the nurses. It was very fascinating to learn from the giants, but nonetheless, let me present my cases. The original paper by Dr. David and Dr. Feindel on 10 patients, one had moderate to severe AR needing conversion to bentol, and 3 had mild residual AR. So residual AR is not unusual. And in his recent update of his 20-year experience, if you look at this graph, right after the operation, approximately 20% of Dr. David's patient had mild residual AR. Again, it is not unusual. And across the globe, the literature supports actually the mild residual AR to be relatively common, although moderate or more is extremely unusual. Importantly, recent paper from Cleveland Clinic showed mild residual AR was associated with the progression of the aortic regurgitation as well as more aortic valve reintervention. So we clearly have to pay attention to this phenomenon. Then a recent study from Korea actually suggests another finding. Within mild or minimum aortic regurgitation, eccentric AR is what the problem is. They lead to progression of the aortic regurgitation later on. From Columbia, we reported our overall outcome of David procedure with a 10-year aortic valve reintervention of 3.9%, which I believe is satisfactory. In my own experience of about 300 patients, post-repair TEE, intra-op TEE showed none had moderate or more residual. Residual mild AR occurred in about 11%, and 32% had trace or trivial aortic regurgitation, which remained stable at the time of the discharge, which is in line with the literature. And I would like to show 3 cases, and I would like to show some of my failures. The first case was a 55-year-old gentleman with a root aneurysm and severe aortic regurgitation. Tricuspid aortic valve, severe AR with a prolapse of the right coronary cusp, nothing unusual. Intra-op echo, the finding showed mild thickening along the free margins. And after putting the commissures within the graft, there's some prolapse of the right coronary cusp was observed, as expected. After sinus has been sutured in, right coronary cusp was plicated. And at the end, there was some annoying high riding sitting of the left cusp, which I will come back to it. But nonetheless, checking the valve height, effective height, water test looks largely okay. But then taking the clamp off, it showed this. Eccentric mild to moderate aortic regurgitation, and with a non-color echo, there is a prolapse and some billowing of the cusp. So we went back in and plicated the right coronary cusp, and this is the pre-discharge echo, so the result was good. The second case was 73-year-old gentleman, the root aneurysm with mild central AI. And patient had a standard valve sparing operation. And at the end, this is how it looked. Central aortic regurgitation. Now, obviously, we don't want to see any aortic regurgitation, but this aortic regurgitation appeared somewhat benign. It's central, non-eccentric. All the cups, the coaptation is happening within the graft with a good coaptation depth. So we decided to leave this alone. The third case was an unfortunate case. 50-year-old gentleman, tricuspid aortic valve, severe aortic regurgitation, similar to the first case, prolapse of the right coronary cusp with a severe aortic regurgitation pre-op. Intra-op, similar to the first case, for some reason, left cusp trying to sit high, and I was trying to find a coaptation, the commissural orientation that allows better the cusp alignment. Nonetheless, proceeded with a valve-sparing usual reimplantation operation, and at the end, the left cusp still is trying to sit high, or else we could say the other two cusps are sitting low. So we put multiple plication sutures. And still left cusp, you can see it's trying to sit high. Water test largely looks okay, but I remember being annoyed significantly with this left cusp. Effective height on the measurement was okay. But then taking the clamp off, there was a good moderate aortic regurgitation. Then grossly looking at the echo, there was billowing of the leaflet of the right cusp. So we went back in, and I'm shameful to show this, but this is the end of a miserable repair attempt, and this patient needed a Bentall operation. In my personal experience of, again, about 300 cases, about 6% required reclamping for the residual aortic valve disease, and 8 patients needed conversion to Bentall. And looking into the detail of the reasoning of the reclamping, the 4 patients had elevated gradient. All of those are very asymmetric bicuspid aortic valve. And severe AR was 1, moderate residual AR was 9, and mild AR occurred in 5 patients. And all of the mild patients, we were able to successfully repair them. But moderate was the problem. Over half needed to be converted to the Bentall. So overall, re-repair technique for residual AR, we can talk a lot about how to re-repair these valves. Typically, the similar principle as at the time of the first attempt of the valve repair can be applied. But we believe more importantly, residual AR should be re-repaired, or we should say should be prevented, especially moderate or more AR should be definitely prevented. We should do very best to optimize the cusp position at the time of the first attempt. How best to do that? I think the previous speakers talked enough about the known principles of the aortic valve repair operation and the reimplantation technique or the remodeling technique. But I would like to highlight 2 things that we've been doing lately. One is optimize commissural orientations in tricuspid aortic valve, as well as visualization of the aortic valve, being aware of it. As you all are aware, and as you heard from the previous speaker, commissural orientation has been very much highlighted in bicuspid aortic valve, and very asymmetric type C are the challenging ones to repair. At the same time, we have experienced several of these cases in which they look like they had tricuspid aortic valve, and yet one leaflet was significantly smaller than the other 2. In these, we have been performing so we call isosceles repair. This is one of such an intro videos. Like now many of you, I measure a lot, maybe too much, but measuring actually helps you to realize the asymmetricity of the anatomy. And we respect the asymmetricity of the anatomy in these cases, and this is the end of the repair. This patient had a good outcome. And looking back, the previous 2 patients that we had residual mild aortic regurgitation, eccentric, and also the one that I miserably failed. Both of those patients, interestingly, had asymmetric tricuspid aortic valve, or based on this, we started to pay more attention to the commissural orientation for the tricuspid aortic valve. Now, our standard technique includes pre-op assessment of the EKG-gated CT angiogram to understand the commissural orientation of the tricuspid aortic valve, which I found it interesting to hear a similar comment from Bart and Ismail's talk about the Ross procedure. Additionally, one really difficult cohort of the patient who we struggle for valve sparing operation is the patient who had the switch, arterial switch. We simply cannot see the valve face down. So we analyzed the facing angulation of the aortic valve in several cohorts of the patient, and interestingly, we found that patient who had switch operation in the past, their aortic valve was actually facing toward backwards. These are very difficult patients to do the valve sparing operation. And we also found in some of the usual aneurysm patients, the valve is facing very awkwardly, obliquely, out of the surgical field. So overall, residual aortic regurgitation, it's an important entity, but let's prevent it from happening. Follow principles of the David procedure, optimize cusp alignment, and we would like to introduce a concept of commissural orientation even for the tricuspid aortic valves. And the repair can be relatively easily done for eccentric mild aortic regurgitation. Thank you very much.
So